I'm absolutely delighted to be here. Thank you for welcoming me, and thank you for being prepared to listen to my talk in English. I'm sorry I have no Greek, but thank you for your patience. So I'm going to talk about a more general topic. Why does paediatric radiology matter? How is it different from adult imaging, and where is it going? So the talk will be in 3 sections, starting off with why does paediatric radiology matter? Obviously I have a view because I am a paediatric radiologist, but I hope to persuade you. One of the most important things is recognizing normal from abnormal. And as general radiologists, we have a feel for this. But as paediatric radiologists, we need extra knowledge and familiarity with all the different stages of childhood and how the diseases and the images will differ. And we need to add that extra knowledge to come to a diagnosis. We need to truly understand there are different diseases, completely different diseases, but there are also the same diseases as in adults, perhaps presenting with a different pattern. We need to work especially closely with our paediatricians, our colleagues, and our paediatric specialists, and I understand some of you in the room are paediatricians rather than radiologists, and our joint task is to bring a voice to children who may not be able to verbalize or identify what is wrong with them. With adults, they take that responsibility largely on themselves. Children need someone to help them. And as paediatric radiologists, we need to be aware of the lifelong impact of imaging. And by that I mean 2 things. I mean radiation dose, but I also mean some of the softer areas like the psychology and the impact of having repeated imaging has on children and how they will become as adults. I think it is not the same as adult radiology. So to start off with, recognizing normal from abnormal, I'm going to show you 4 examples, which is a tiny amount of what we all need to know. I'm going to show you something to do with growth plates, marrow signal, normal structures, which look different in childhood, and maybe patterns of fracture. And I've chosen these 4 topics because they go across the whole breadth of paediatric radiology, and they're not especially specialist. And I come from a tertiary, a high-level hospital, and I'm very aware we have a different population of children. I hope this will have something for everyone. So if we look at the knee and we look at the growth plates, I'm just going to see if this works. Sorry, just trying to find the laser. Oops, no. The laser. Sorry, I don't know how to work the laser. Never mind. Thank you. While the gentleman's helping me. So these are 8 very similar images. Which bit is the laser? Oh, thanks very much. Thank you. And you can see at first glance, there is very little difference. But the area I'm interested in this slide is the tibial tubercle. And the tibial tubercle can have a very different appearance in normality in children with many ossification centers. So you need to be aware of this, not to undercall or overcall. Now there is a clue here from the image. I've given you an image with an arrow on. The arrow is not pointing to the abnormality of the tibial tubercle, which is actually normal. The arrow is pointing to the overlying soft tissue swelling, which tells us that this patient has Osgood-Schlatter, unlike this patient who has no soft tissue swelling. In this patient, the arrow is pointing to a fracture of the tibial tubercle, unlike in some of these other patients who don't have fractures. But this one here, some of you may have spotted, also has a fracture. So we need to be aware of the different range of appearances. In the paediatric bone marrow, and I recommend this paper to you that is freely available. It's from Radiographics, no subscription necessary. This excellent paper describes the change in the bone marrow through childhood and adolescence. So you can see that the bone marrow in infancy is largely red marrow, and then it gradually changes all the way through to yellow marrow. In stress or medical illness, this pattern can change. If I show you these MR pictures, these are all T1 weighted of normal patients. You can see that the red marrow is very dark, but this is gradually replaced by the yellow marrow, which is more fatty. Now, this patient at the end is an 8-year-old who has ALL. Now, we know, and you can see from the example, that it's okay for this to be very dark if you are 2 years old. But it's not okay for that to be very dark if you are somewhere between 5 and 10. So this is abnormal. This child has got marrow infiltration, but we need to know which image we are comparing it with. Sorry. Just trying to get out of that. So normal structures, you're probably very familiar with how the thymus can look on a chest X-ray. For adult radiologists who do no paediatrics, it can be quite scary to see this mediastinal mass. But actually, it's a really obvious thymus with the classic sail sign if you're used to seeing it. But if this was a more central mediastinal mass, how would you work out if the patient has a tumour or if they have a normal thymus? And in radiology, in young children, we have the joy of ultrasound that allows us to look through the sternum, because it's still cartilaginous, or in a parasternal plane, and we can see the thymus exquisitely with this absolutely classic pattern of thymic tissue with little dashes and little dots. So I would suggest in a patient in whom you can do an ultrasound of a mediastinal mass, you would do that first. You would not do a CT on this patient. You would do an ultrasound. And if you can see the whole of the mass, you can send the child away with a normal thymus. Patterns of ossification are very important. And many of you in medical school will remember how around the elbow there's a specific pattern whereby the ossification centres appear and subsequently fuse. This is really important in assessing fractures. So in an adult fracture of the lateral condyle, you can see how it goes right through the bony part of the, sorry, that keeps happening. Right through the bony part of the lateral condyle. But you can see in a child where the epiphysis is still cartilage, that actually even though fracture might go through the same way, there is only a tiny fracture, but it's like the tip of the iceberg. And you have to recognise that and look at that. No, it's not an ossification centre, and no, it's actually quite an important fracture that may be going right through the growth plate and into the joint. So we have different diseases and different disease patterns. We have congenital diseases, which are largely unknown to adult radiologists. We have diseases that can look the same unless you know how to look. So one of my threads is how to look, and that is very different in paediatric radiology. We have diseases that look different from adult diseases. Children's cancer looks different from adult cancer. And as I've touched on, we have differences in development. So if I show you this picture, a paediatric radiologist would probably say this is an MCDK, a multicystic dysplastic kidney. An adult radiologist who wasn't perhaps having a good day might think that this is hydronephrosis. And the reason that it's an MCDK is we have the cysts and we have the stroma in between. So what is this? Is this an MCDK or is this hydronephrosis? So paediatric radiologist would say, that's hydronephrosis. Paediatric radiologist go, panic, not sure. And the reason that this is actually hydronephrosis is because as a paediatric radiologist, you will scan through very, very carefully to see if all of the cysts can join up to the central renal pelvis. And this is not an MCDK, this is hydronephrosis. We have different diseases, and an adult radiologist looking at this might think that there is some terrible disease of the liver, and they would be correct. But there is a clue on the middle image. If you look at the kidneys, we have little cysts in the kidneys, and then there is a lovely image at the end. And I'm sure that you have all guessed that this is, in fact, Caroli disease. And then we have a crossover. So an adult radiologist looking at this would go, the patient's got a pacemaker, and then if they were having a really good day, they would look at this area here. And they'd go, well, something else, maybe it's a metastasis, maybe it's a lung nodule. So they would order a CT. And on the CT, they would do the topogram, and they would go, yep, we're right, there's something here. But this is a pulmonary hematoma, sorry. And you can see the characteristic enhancement pattern. So whilst this is more commonly seen in adults, it is seen in children. So pediatric radiologists would really matter here because they're aware of both adult and childhood diseases. And we see different disease patterns. And you're probably all familiar with rods in scoliosis, maybe an idiopathic scoliosis. But how many of you very quickly saw the abnormality at the top here with the disconnected shunt? And so we're very used to looking at shunts in childhood, and hopefully we would look at the whole image and see the shunt as well in a not an idiopathic scoliosis, but a more complex condition. And then we have entirely different diseases. This one is quite difficult. This is a fluoroscopy study. I did this some years ago, and this is a cloacal malformation. And we will now image that in a very different way. We will start off with fluoroscopy as a roadmap, but this is no longer sufficient for complex reconstruction. And we will now produce images like this that allow us and the surgeon to fully understand the complexity of what we're looking at. This is osteogenesis imperfecta with a classic softening of the skull and what we call the tam o'shanter, which is the name of a funny hat, tam o'shanter skull. You would not see this in adults. And this is a very rare disease, and if you ever see this, you are very lucky, or unlucky, very lucky, because it's absolutely pathognomonic. It means the image tells you the entire diagnosis. And this is trichothiodystrophy, and you can see that the proximal skeleton is very dense, and the peripheral skeleton is very osteopenic. And this is absolutely classic for this very rare condition. But these are the sorts of things that a paediatric radiologist will appreciate. And then, of course, conjoined twins, they're a rare condition, but paediatric radiologists absolutely have the expertise in imaging these, how to image them, which twin to inject, which phase of contrast to use, which planes to reconstruct in, and what the clinical and surgical questions will be. So as part of discussion about why paediatric radiology matters, I would really like to take, and be rather cheeky, to take the opportunity of us working as a clinical team and having a quick discussion about that. As you gathered from earlier, I'm really passionate that we give children a voice when they come to medical attention. We're so privileged to be able to do that. We're the advocates, and we're increasingly a key part of the clinical team. And when we really matter in the clinical team, we can change everything for the child and for the physicians looking after the child. But we're also part of the social team, and we're seeing more of this in our practice than we previously did. And I think we all, as doctors, need to be very aware and open to what the child might tell us when they trust us. And that can be non-accidental injury, or they're being abused at home, just the tiniest little phrase that we need to be sensitive to when we're doing the ultrasound or doing the fluoroscopy. In the UK, we're becoming very aware of female genital mutilation. And as the paediatric radiologist, you may be the first person to see this if you are doing an ultrasound or if you are doing fluoroscopy. This is illegal in Europe and in the UK, and we've just 2 weeks ago had our first successful prosecution for female genital mutilation. And of course, for the paediatric radiologists in the room, I expect most of you have had the misfortune to scan an adolescent child, female, who has a pregnancy that she may not know, and certainly her parents may not know. The value of the multidisciplinary team in dealing with these issues cannot be underestimated. So finally, on this area, I would like to bring to your attention the impact of lifelong imaging. I hope most of you know this, so forgive me for going through this. But the impact of ionizing radiation in young children is really very significant. And you can tell from the shape of the curve that the time they are most affected is the time when you and I will be seeing them. With a really steep curve and females particularly affected, I would plea that you think very carefully about using radiation in children of this age. And you can see on the right-hand side the cumulative radiation that children get with specific tumours. And then from the text, and I'd recommend this paper to you, you can see that with the exception of brain tumours, repeated surveillance imaging using ionizing radiation adds very little to the lifetime survival rate of these children because they usually present symptomatically. So please think about that when you're repeatedly imaging children with tumours. And then 2 words on the psychology of this. There is an increasing body of evidence that imaging children and medical stress can lead to post-traumatic stress disorder. And in this paper, which was about children with congenital heart disease, between 12 and 31% of children undergoing cardiac surgery develop PTSD. I think that's shocking. We have a part to play in that, and we need to remember that. And this separate paper particularly raises, I'm going to be very careful now, that invasive medical procedures, especially in children under 6 years, are likely or possibly likely to cause PTSD. So when we do micturating cystograms in children who are 18 months or 2 years or 4 years, this will undoubtedly have an impact on them. So please bear that in mind with your imaging. Okay, so how is it different from adult imaging? I'm going to move away from some of the diseases and just mention quite briefly actually about some of the different ways we actually do the imaging and the different techniques. We use the same different modalities. We have a much greater use of ultrasound, very little use of CT, and a much greater use proportionately of MRI. Sadly, for paediatric radiologists, much less can be done remotely. It's much more difficult to sit at home and read the images. You usually need to be here. Often it can't wait. As we've covered, the structures and pathology look different. There are technical issues with a very small child. If you do need to give contrast, you may have a tiny cannula. You can't give contrast at the same rate. You then need to think about how you deliver the contrast to still obtain the diagnostic image. And the child needs to cooperate. Sometimes adults don't, but most times they do. Children need to believe in you and trust you and be calm. As I say, ultrasound's unbelievably useful. We couldn't exist without it. CT is only now really used in the chest, in cardiac CT, bones, and in diagnostic problems or emergencies. In London, we use MRI as the next most frequent investigation after ultrasound, other than plain films. And nuclear medicine is changing so rapidly. It is no longer the Cinderella. It actually is bringing together many modalities, nuclear medicine, CT, PET, PET-MR, all coming into one examination that brings all of that information together. A really exciting field. So here's a technical example of how it is different from adult radiology. Most adult radiologists, and maybe a lot of paediatric radiologists, will image the child's kidneys with the child lying on the bed, supine. These are the images they might get. And they might have a child who has hydronephrosis, and this is hydronephrosis. They will image the kidney longitudinally and in transverse. They will image the left kidney, where there's a little bit of fullness, but not much, longitudinally and transverse. And they may get some nuclear medicine showing that there is slow drainage from the right kidney with a slow drainage curve. However, as a paediatric radiologist, you will also scan the child prone. This is not routine in adult radiology. When you scan the child prone, you see there is a difference. You can see from my arrow, we're now on the back of the child, that the axis of this kidney is pointing posteriorly, straight out onto psoas and the posterior abdominal wall. And in transverse, the axis is pointing horizontally, straight out onto the psoas muscle. Whereas the normal orientation, when you scan the child prone, is that the axis of the renal pelvis will be inwards and will be angled. This is such an easy examination to do. Most people don't normally do it, and it changes everything. Because this child needs a nephropexy. They need the kidney lifted up so that it can be slightly rotated off the psoas. And with a nephropexy only, and not a pyeloplasty, this child has had all the drainage of their kidney relieved. These are the post-nephropexy images. But if you hadn't scanned the child prone, you would miss this, and the child would have the wrong operation. They would have a pyeloplasty, and the renal pelvis would still come out onto the psoas, and it would look like they'd had no improvement. Here is a different sort of modality, which is different. So this is a child who's got a Wilms tumour, and you may do this, forgive me, I don't know. But we do ADC imaging to see, after the chemo, whether the tumour is involuting. If you actually look at the size of the tumour, it's actually not very different after the chemotherapy. But if you look at the signal, it has completely changed. When the signal is dark, that means it's full of very densely packed tumour cells. When the signal goes whiter, that means the tumour is showing necrosis and is actually showing an excellent response to the chemotherapy, which you would not know if you had not done that sequence. So going on to how the child cooperates, this is our new suite. This is our SPECT CT. And I would suggest to you that this looks very plain, very like a hospital, not very friendly, looks like a big machine. However, when we turn the lights on, it looks like this. And the child comes into the room and they think they're going to the cinema. And they lie on the bed and the image above plays the video or the film, whatever they've brought. When they need to lie on their side, or if their siblings are in the room, they turn on the side and everybody, the whole family, watches the film together while the child is having their investigation. They can choose the colour. So girls choose pink and boys choose blue. And I hope this is going to run. So you can get the experience that the child has when they're having their nuclear medicine examination. So we're very lucky to have that, I recognise that. But it shows you some of the ways in which we make it a completely different experience. The children are queuing up to have their imaging. Okay, we're nearly through. Where is it going? I have two areas. I would like to very briefly talk about workforce, because radiology, adult or paediatric, is only as good as us, the people who do it. and then some of the very new techniques. I only have the data for the UK. We have one paediatric radiologist per 50,000 children. I don't know if that's the same in Greece. I suspect not. We're very fortunate. We still find this quite a strain. And you can see, although our numbers of radiologists are increasing, the number of examinations are increasing faster. As a result, I think an issue across the profession is that of burnout. And we need to be very sensitive to this and look after ourselves and look after our colleagues, as well as looking after the children. So if I show you this, this is a very recent paper. This is from autumn now, 2018. This surveyed paediatric radiologists through the SPR, the Society for Paediatric Radiology. And huge numbers of people, 66%, reported feeling emotional exhaustion and depersonalization, which is the prime indicator for burnout. I don't know how many of you do on-call. I do full on-call. I've been a doctor nearly 30 years now, and I have only had 6 months of not doing on-call in that time. And the on-call is one of the things that leads to burnout. I don't have a solution to that, but I think awareness of these factors and not just ignoring them is really important. Coming to a meeting like this gives joy to my profession and to all of us, but it's only part of what we do. And the other thing, the other way in which the workforce is changing is the differentiation, the increasing differentiation into subspecialties, paediatric radiology being one of them. It is becoming more and more important to have paediatric radiologists with support from adult radiologists with a special interest, but it is becoming more differentiated, as I have shown you. And one of these very interesting papers, this is also quite a recent paper, looking at the rate of difference between specialist paediatric radiologists and images reported by other radiologists. I'm a body radiologist, and there's a 32% discrepancy in how a specialist paediatric radiologist would read the images compared with a general radiologist. I think it's particularly important in areas where it makes a material difference and the child could be very, very sick. So in appendicitis, I think these numbers are shocking. There was only agreement in 51%. And in interception, agreement in 57%. That means there's disagreement in nearly half of these incidents. We can't ignore that. We need to continue to educate ourselves and have the right doctors doing the right tests. We need to train and enthuse our junior staff. We need to, for us, to avoid burnout, maintain patient contact. And as you can see in my second point, I think good feedback from a patient is pure gold, absolutely what makes us do the job. But we do need to be open to technologies, and AI may be one of those. I know the next lecture is that. And we need to work as clinical partners. I'm going to read that one out. I'm just going to show you 4 slides of some new technology. This is part of our routine new technology now. This is a Great Ormond Street image using rotational angiography to demonstrate the stenosis in a renal transplant, which is otherwise extremely difficult to see by ultrasound because of where it is. And you can see how that's exquisitely delineated for the surgeon. It was detected on ultrasound because of the aliasing at this very narrow point, and you can see the vessels are almost exactly replicated. So an exquisite image, but we can present it to the transplant surgeons in a way they understand. These are some of Marilyn Siegel's images showing how new techniques in CT can reduce a lot of the artifact from spinal rods. It makes a CT technique much more useful at a very low dose. 3D printing is becoming a real factor in how we use our images and how we educate the clinicians. And then I have 2 slides from our own institution. I'd like to credit my colleagues, particularly Martin Kostolny at the bottom, who gave me these images. And this is how we now do our cardiac imaging. So we have a medical scan as usual. We then have medical images. We create a 3D model, but now we also do virtual reality. And we do this as part of our core business at Great Ormond Street. So these are the images we are now producing. We do this for nearly every patient. Whilst you can have the 3D model, it doesn't allow the surgeon to go into the image and go into the vessels and turn them around in the same way. you can see, although this is produced in grayscale, it gives you much more information about how you go in. This is going to play. So this is just showing, just get this again. Sorry.
So this is the tragus arising from the right pumping chamber. You just see the right pumping chamber. If I grab the heart and turn it around a little bit, you see the right and the left pumping chamber.
And so he is able to practice the operation before he starts.
Around, you can see.
And so AI is going to come and help us. AI is our friend. It is going to take away the stuff that we spend so many hours doing where we add little value. And it will allow us to add value to the bits that I've explained. So much so that only, 2 weeks ago, January the 30th, 2019, Radiology, the big, massive radiology journal. Whoops, sorry, I'm giving away my thing. Oh, how do I escape from that? Sorry, need to go back into. Ooh. I'll just try and get back one. Wiped myself off. So just 2 weeks ago, Radiology started a brand new journal dedicated to AI in radiology. You will see this is going to be the future for us. I just need the last slide, actually. Very, very last slide. And I would like to thank you all for having me here and for indulging me with your interest and your attention. Thank you very much.